innovation since 2021. His previous role at QNuro include chief engineer and head of research and development, showcasing his exceptional leadership and technical expertise. So over the year, Bharatwaj has held a prominent position in various organizations. So, and he has the expertise in signal processing, medical devices, sensors, nanotechnology, biomaterials, and he is proficient in tools like MATLAB, LabVIEW, and scanning electron microscopy. He has a proven track record in research and development as well as in product innovation. So, with this background, I welcome you, sir, for this workshop. Over to Rahul Bharadwaj, sir.
Thank you so much, sir, for a nice introduction. And thank you all, especially Dr. Adel Rasu, for inviting me to give me a chance to share my experience and speak on the topic, which I will be speaking on today. Having said that, I'll now start my presentation and then we will subsequently engage on that one. So can I share my presentation here?
Sir, kindly share your screen.
Yeah. Let me know when you see my screen.
Yes, sir, your screen is visible. Yeah. You are
Okay.
audible.
Am I audible enough to everyone?
Yes, sir, you are audible.
Great. Okay. So today I'm going to speak on the role of deep neural network in the Alzheimer's and dementia diagnosis, navigating challenges in the early detection. So when this topic came to me, I was actually happy because part of it we are also working in our company, which I will discuss later in a later phase of this presentation part. So let's first start about the Alzheimer disease. So it's very common term nowadays. So I'm sure most of you would have heard of it. Though there are a lot of text in this presentation, I just put it purposefully so that the concept should be clear to everybody. So Alzheimer disease is a very common nowadays. It is same like how it is for the coronary heart disease. It is for the brain disease. So it is so the result of this is it causes damage of nerve cell, and because of damage of nerve cell, the people get a lot of symptoms, right? For example, related to the memories, so they start losing the memory, and other symptoms also developed along with. So other symptoms are like while talking, walking, all the things are reflected because nerve cells gets degenerated. Population of American, if you see there, there is a report there on a website where it says that the population of Americans age 65 and older is projected to grow on from 58 million in 2022 to 82 million by 2050, which is a scary data. So if we can see here, let me just on my pointer. Yeah, if you see this pie chart, we see that how these are affecting. And one of the fact over here is Alzheimer disease was officially listed as sixth leading cause of death, but since 2019, it shifted to the seventh position because COVID was one of the leading cause of the death, which was at the position 3. So this is so we can understand from this fact how deadly this is going to be. Now let us speak a little more about the Alzheimer disease and dementia. Dementia is nothing but the symptoms. For example, I would like to demonstrate in such a way that we have a headache, right? So the when we see we have a headache, it is a dementia. But what is causing that headache? Root cause of because there can be n number of reasons for the headache. So that specific cause of that headache, we can say that is Alzheimer. So there can be many reasons for the dementia, but dementia caused by Alzheimer is one of the dementia, right? So if we see the if we talk about the reason for the Alzheimer, it is caused by the fragmentation protein which breaks that beta amyloid protein and the protein tau protein. One is inside that cell and other is outside the cell, and because of that degradation, the brain shrinks. And when brain shrinks means the neuron degenerates and degrades, and because of that the brain shrinks and we develop these symptoms called dementia. So it doesn't happen all of a sudden like other diseases. It happens in a continuation. It is a progressive disorder, like preclinical AD, no symptoms but possible biological changes in the brain, then mild cognitive impairment due to AD, and then a dementia due to the AD, mild and severe, like mild, moderate, and severe. It progress, and that is a whole reason for this presentation. That how do we track these changes and the progression of dementia? It is better to predict in early phases. It is like a cancer stages, right? It is better to catch in early stage than regret forever, right? So there are a lot of techniques which we will discuss in a subsequent slide. So just I have put it for you all to understand the other causes, common causes of dementia. So there are many causes for the dementia. uh, okay, off to this topic, how much time do I have? If I can know, then accordingly I will fine tune my presentation, uh, if
So
anybody can.
it's 90 minutes. It's up.
Okay, okay, so we can discuss this in really relaxed manner. But interrupt me when I go little derail from the topic, right? So let's again come back to the topic, which is common cause of the dementia. So Alzheimer, which we have just now spoken and discussed, is one of the cause of the dementia. Then cerebrovascular disease, in which blood vessels in the brain are damaged or brain tissue is injured. So this is about the nerve cell. This is about the blood cells, right? And then third cause for the dementia is the frontotemporal degeneration. In that nerve cell, the frontal and temporal lobes of the brain dies, and the lobes of that particular brain shrinks. But it is not because of the beta amyloid and then the tau protein. There is a different reason for that nerve shrinkage. And then on the next type is the hippocampal sclerosis and Lewy body disease, mixed pathogenesis, Parkinson disease. So it is little off from the topic, so I will not emphasize on all other types of cause of the dementia. So let's move to the next slide. So this is a condition of our Indian system, where where we can see that age standard dementia prevalence among the adult 60-year and the older in the states of the India, how it is prevalent. So you can see this heat map where green is minimum and then the red is the maximum, which is shown. Uh, let's see the data about the Alzheimer disease, the little scary data. So research shows that most of people currently living with the dementia have not received a formal diagnosis, right? And in high income countries, only 20 to 50% of dementia cases are recognized and documented in the primary case. So it is, again, I would like to correlate this with the cancer. In the cancer, especially in the first 2 or 3 stages, it is not caught, but when suddenly it reaches the fourth stage, it is caught, and by then it becomes very late to give the treatment for that one. So it is similar kind of story in the Alzheimer as well. So the another thing is someone in the world develops dementia every 3 seconds, which can be really, so this one, so this is very horrible data, and there are over 55 million people worldwide living with the dementia in 2020. This number will almost double every 20 years, reaching 75 and all. You can just read out this data. So the purpose of showing this data is to understand how important this can be to have the prediction of early detection of of Alzheimer, uh, and we can save a lot of lives. So it is again the I would say it is the statistics. I'll just skip this statistics because by now I have given the enough information about the severity of this Alzheimer disease. So now let's go to the next topic, which is the early detection of the Alzheimer disease. So there are two ways of detection of the. There are two approaches, in fact, to detect the Alzheimer disease. One is invasive, and other is a non-invasive approach. So most hallmark characterization of Alzheimer disease is through the CSF, cerebrospinal fluid. It is purely invasive procedure where we take out the CSF and we find out the stages of the Alzheimer disease. And the drawback of this one is, of course, when I say it is invasive, that itself is the biggest drawback. We don't have that procedure. That's the point of presentation is how we can predict the stages, early stage of the Alzheimer disease based on the technologies. The other invasive approach is the blood component monitoring. So there is a debate in that one. Some researchers says that blood component monitoring can be invasive. Some says that it can be non-invasive, meaning you just take out the drop of blood and then nowadays the people say that just one drop of blood and we can just predict it. So it is not actually the non-invasive, so it is kind of middle of that one. So okay, just for this argument's sake, I have just kept it in the non-invasive criteria. Now let us move on to the purely non-invasive approach of AD detection. One is imaging. So definitely, MRI is one of the imaging technique of the brain, and CT scan and PET is other techniques of the imaging, and then wearable sensors, which is IMU. So as in the previous slide, I had told that dementia, the symptoms of dementia is also the walking, meaning from the walking gait analysis, we can find out that the person is having dementia or what stage of dementia so and so person is having. So IMU is nothing but the inertial motion unit sensor. So just which will give you the information of accelerometer, gyroscope, and magnetometer. So based on that one, we can find out the gait analysis. This device, this IMU, you can see which is there in your watch also, smart watch if you wear. And based on this IMU, actually all the steps which it counts, like your watch gives how many steps you walk and how fit you are. So those algorithms are based on the IMU only. So IMU is also used in this gait analysis for detection of dementia caused by the Alzheimer. Next one is a biosensor. So based on the speech, so there are many sensors which can actually track how do you speak, and then the pattern of speech, and based on that it will predict if the person is having dementia caused by Alzheimer. So these are the very accurate. So of course, anywhere you go, invasive will have upper hand compared to the non-invasive. But we researchers are trying to find out the best way to predict the Alzheimer based on non-invasive method, either by imaging solution, wearable sensor, or the biosensor, right? But there are of course a lot of challenges when we deal with these sensors. So for now we have taken this part in our as a scope of our talk today, and these two I have not considered. Otherwise, this would have been very long presentation. this would have been itself a very big topic. So when we progress from here, we will talk on the imaging part. So now in line with that one, let's now talk about the deep learning. So I'm now making the platform for the prediction of the AD, Alzheimer disease, through the non-invasive way. So while non-invasive way holds the potential for early prediction of AD, the data generated from these techniques poses several computational challenges that needs to be addressed. And there are like AI based AL and DL, machine learning ML and DL in fact are used regressively in the prediction of the Alzheimer disease, and a lot of and similarly a lot of statistical analysis is also done as a part of analysis in this one. And best part of DL is the accuracy of this one is uh, good nowadays. If you refer the literature survey nowadays, the accuracy of this has reached to 85 to 90 to 93%. So different researchers opt the different algorithm for the DL, and they report that how much the percentage of the accuracy they get. So this is the illustration of the AI and DL application in the Alzheimer disease using non-invasive data clinical biomarkers. So as I explained, so these are the types of sensors, right? Temperature can be there, or watch can be there, or this can be IMU. So there are different types of sensors. So this we take as a non-invasive data source, and this will go in the analysis where we have the AI and DL techniques, and then we go for the prediction. So for now we will deal with one by one, which is, as I said in my previous slide, we will, for the scope of this presentation, we will take the imaging. So let us see here. So what are the steps involved in the diagnosis, not diagnosis, in fact the prediction of that one, and of course the to predict if somebody is having Alzheimer or not. So we take the data acquired from the MRI, and we do the data processing. So this is very standard steps. It is relevant to the all biosignal processing or the image processing, and related things. So when we acquire the signal, definitely it will comes with a noise. Every signal or image comes with a noise. So we have to remove the noise, and then we have to do the data augmentation, and then we have to split the data in the training data set and validation data set. So that is a major part of the DL, deep learning, where we have to, if it is a supervised learning, so you have to train the data and then you have to test the data. And next and last part is the feature extraction and classification. So there are here many, so in every step there are different techniques involved, and researchers takes different techniques for each part. Like for data processing also people opt different techniques. For feature extraction classification also people take different techniques, and based on that they product how their model was, like how accurate their model was. So now let's, as I said, we will discuss part by part now. So we will now go to the data acquisition stage. So the first stage is the data acquisition of the raw data. In that one, we take a different imaging technique. So as I said, we take a different imaging technique, which is MRI is one, PET is second one, third one is the fMRI, and fourth one is the computed tomography. And then these are the so what we do is Alzheimer disease diagnostic method is that is the memory test, and the brain imaging, and the numerical laboratory test. And then from the brain imaging we take MRI and then PET data and then the CT scan. And now let's go about the pre-processing technique, where we have the data sets, especially the images. So when, as I said, when we take any signal or image, it comes inherently with a noise. So we have to filter that out, and there are a lot of filtering technique available in the literature, which we can opt. And if you see, there are, so learning and classification, there are, as I said, which was the last part. So this is the one. So CNN, convolutional neural network, then recurrent neural network, TNN, AE, BTN. So these are the learning and the classification part. And then actually this should have been the first anyway. So the second one, not second, this is the first one and this is the second one. So in the image pre-processing and then the data cleaning, we have the intensity normalization, contrast enhancement, denoising process, brain extraction, data augmentation, and then in the denoising process, we have the median filter and the Gaussian filter. So these are the things which we will discuss first, and then we come to this one, and then we go to the last part, which are the challenges we face. So it is the is my pace fine or I'm slow or fast? You can give your assessment, sir.
It's fine, sir. It's fine.
Okay, thank you. So intensity normalization. So here we go. So we just discuss one by one: intensity, contrast, denoising, brain extraction, and so on and so forth. So let's discuss about the brain intensity normalization. So this we can see that it is used to map the intensity of all the image pixels of the reference scale in general. So we can see that this is the MRI data, which is before the intensity normalization, and this is the after intensity normalization. So when we get the data to have the uniformity in the data, we have to do the intensity normalization. And then there are chances that the contrast of the image which we get may not be optimal. So we do the contrast enhancement, and contrast enhancement is the difference between the highest and the smallest pixel intensity. So in following equation, so this is the contrast enhancement, and we have to bring it to the optimal level to improve the quality of image and increase the contrast of the border of the image. That actually helps us to differentiate between the organs of the image we get, right? So this is the equation. You can get this is standard equation, you can get it anywhere. So this is the contrast image, right? Enhanced pixel, and this is the what we have the value of each pixel. This is the minimum, and then the maximum f max is the maximum value, and we can calculate from that one. The next process is the denoising. So as I said, every image which comes with a noise. It can be because of the many reasons. So to classify it in a better way, we have to denoise it. So there are different filters. It is not about these two, but I have taken these two because these two are the very much popular. It's not because these are the only two which are available. Median filter and the Gaussian filter. So in the if you can see that before median filter and then the after median filter, and bottom of the image you can see before Gaussian and after Gaussian filter. So the median in the median filter, if you see the median filter identifies pixel as a noise by matching each pixel in the image to the neighboring pixels, right? And the filter which is called as the kernels, the specific size, right? Gaussian filter also helps in denoising the image. From the naked eye, it may not be very visible, the difference between the median filter, but it is there. It is a technique which is available. Then brain extraction and skull stripping. So when we take the image from the apart from the brain, apart from the image of the brain, other tissue cells also comes, which is like eyes, neck, and all those things which we have to exclude from this study. So you can see that this is scalp, right? And we have to remove this part, and this is the uh, image which is desired for the further analysis. And then definitely the data augmentation, it is very important when we get the set of the data. So it is the one very common problem is a overfitting problem. So this overfitting problem we also generally find in the CNN, convolutional neural network, but there are ways to pooling the data. There are other ways to reduce this overfitting problem. So after we collect the data, we can apply this augmentation to increase the image diversity in each class. There are different techniques, which is cropping, shifting, shear, scaling, and zooming for data augmentation. So this was the very general topic. So I didn't dealt in detail over here. So we can refer this technique for the data augmentation. Now so data processing is done now. So we go for the classification. So in the classification, there are different techniques like CNN, convolutional neural network, RNN, deep neural network, DBN, and then the autoencoder. So this is supervised learning. This is non-supervised learning. So it is like so these are the tools, in fact, right? So these are the tools, and researchers take a tool. And if you go to previous slide also, there is no standard method for any process which people take. It is like fit and finish. uh, they do experiment, and it all depends on the day. There are several factors on which your design of experiment depends. So there is no any golden rule for selecting any specific ways. So many people take CNN, many people take RNN, many researchers take DNN to for the deep learning technique. But this CNN is considered to be the most favorite, and it seems it is most favorite because it gives the best accuracy. So that's why people opt CNN as a most, and then some people also take DBN, and some researchers also take autoencoder, that is non-supervised learning. So there is no fixed rule for that one. So we will just discuss one by one quickly, and then we go for the challenges part. So if you see the deep neural network, so it is a supervised learning technique, right? So there are many hidden layers in this one, right? uh, so it actually solves all the complicated problems, and it also solves the problem which is has the non-linear relationship, right? So, and these are the pros and cons. So it has a high accuracy because of the multiple layers, hidden layers, and the feature learning. It has good scalability, versatility, and state of art results. So everything comes with the pros and cons. So if anything is complex, then inherently it will have a lot of computational requirement. If anything is complex, and the lack of interpretability, vulnerability of the bias in the track, overfitting is another problem, which is factor in the CNN, convolutional network. And then we have the recurrent neural network. So it also uh, so it is kind of feed for it is something similar to the feed forward, but not actually like that. This is mainly used in the word processing, right? Memory and hidden state is there. So if you see memory state and then the hidden state, so when you type on a word file, so that is prediction. When you type one word, right side you will say that there will be a suggestion to that one. So that is mainly based on the recurrent neural network, right? Now let's talk about the autoencoder. So A is unsupervised learning. So and it can be unlabeled data set comprised of features of the encoded data. So it has mainly two parts, encoder and decoder, and it has a kind of black box kind of thing, which is code, right? So the encoder converts the input data, okay, and then decoder rebuilds the code to the output, which looks like an input, okay. So input is given to from here encoder, and this is kind of a black box, and the output is given. So it is kind of since it is a unsupervised learning, it will kind of collect all the information from here, and it will give the information out from this part. Uh, Okay. So, sorry, it has definitely pros and cons. So, the pros are the effective dimensionality reduction, captures nonlinear relationship, and it doesn't need any level data. And cons are prone to overfitting, high computational cost, requires high data sets, and limited interpretability. Deep belief network. So it is again the supervised learning that can link the unsupervised features, and it has two parts. It is structured in the stack, which is called as a restricted Boltzmann machine. So you can see here, which is extract feature and then reconstruct the input from this part. So pros are effective, unsupervised pre-training, good initialization of the deep network, reduces overfitting on the small data set, handles high dimensional and nonlinear data. Cons are the high computational cost and sensitive to the poor initialization, limited scalability for the large data set, difficult to interpret. Now let's come to the convolutional neural network, which is considered as a most favorite because it is ideal in many ways, which we will discuss over here. So it is also a supervised learning CNN, and it composed of several convolutional layer, pooling layer, activation layer, and fully connected layer. If you see if it is input data, and then there are the middle part which is convolution layer and the pooling layer, and it is fully connected layer, and then there is a prediction after that it takes place. Okay, so a lot of text here. Okay, so pooling. So here it is. If you see that there is a convolution layer and then the pooling layer. So activation function have numerous types of the sigmoid, and that rectify linear need to create the features map. And pooling layers actually reduce the dimensionality, which gives the most important feature, and they are considered as a downscaler. And there are many architectures are there, and the data set is also available for the uh, CNN, which are these. So we can actually get this data set and the several architecture trend image from the different sources. So there are different applications of CNN also. So not only in the Alzheimer prediction, in the other application also CNN is used for various application. Again, I would say there is no any hard and fast rule for this thing, but the only thing is CNN is considered to be most accurate, less computational, and it has actually less cons than the other techniques. So image recognition in the classification is one of the biggest applications in an object detection, image segmentation, face recognition, self-driving car, which is nowadays it is in vogue. People, it is this is the new thing that town. Uh, a lot of effort is being given on self-driving cars, and then the natural language processing, and then the medical imaging. So we can see how important CNN is in the current research scenario, where where it fits almost all the latest research field. Yeah, everything, as I said, everything comes with the pros and cons, advantages and the disadvantages. So advantages we will quickly see. So if it is efficient feature extraction, translation invariance, parameter sharing, scalable. Disadvantage is definitely high computational cost, data dependency, lack of interpretability, vulnerability of the adversarial attack. So these are the disadvantage, and these are the advantages of the CNN. Now let's move to our next topic, which are the research challenges. So when we have just now we have seen when we have all this kind of deep learning techniques. So and we also saw that every technique comes with the pros and cons. So definitely, if something comes with the cons, then it will have a lot of challenges to handle. So we will see how to handle these challenges. We can't mitigate fully, but we can brainstorm on that one and try to address those things if we can reduce, if not fully. So there are three ways. There are three major challenges. First one is the data related challenges. Other is second one is the algorithmic challenges, and third one is the clinical integration challenges. So this is the major part, data related challenges. So because we have the limited annotated data sets, and that is the first part. Second point is variability in the medical imaging quality and the patient data. Sometimes the data set which we get on the internet is not consistent, and sometimes it will be annotated badly. For example, if we are planning to get data set for the Alzheimer, we might get for the other neurodegenerative disorder apart from the Alzheimer, but it will be annotated badly. Then it requires a large amount of label data for for the optimal performance. And third one is of course the cost of the collection. So best way is to form a research community and keep pulling the data, keep appending the data, so that there will be a good pool of and good annotated data set, and so that the future researchers can use those data sets to reduce the challenges, which could be a potential major change in the future. Another challenge is the algorithmic challenge, ensuring model accuracy and reliability, and risk of overfitting in deep learning models. And third one is clinical integration challenge, where resistance to new technologies, right? So balancing AI tool with the human expertise. So these are the practical problems which we can have. But yeah, this with a mutual understanding, this can be solved. But this data related challenges we really need to solve. So we will be taking this data related challenge. I'll take this part in the subsequent slide, and we will address this issue. So data and the algorithmic challenges, majorly the data challenges is availability of the large data set. So very rarely there will be a good availability of the large data set, and if it is there, the cost is huge. So that comes with another problem. Next one is overcoming data imbalance problem. Then multimodality image in the classification, another major third problem. Fourth one is collecting necessary information, sometimes because of the bad annotation and bad way of collecting of the data. Sometimes it is not collected necessary information. Then the neuroimage noise manipulation. Yeah, it's true. It happens sometimes. Overfitting problem. Yeah, kind of very genuine and innate problem. Uh, Maybe acquired also. And then the hybrid approach can be the another challenge. So we talk one by one on all these topics. So I'll just take a pause of a minute to have some water. Sorry. Yeah. So availability of the large data set. So so there are few data set which are available. So one which is very famous is ADNI, Alzheimer disease neurodegenerative imaging. So it is initiative. It is over here. Yeah, you can access, and then you can have the OSIS, outcome and assessment information set. So these are the website which are available for the large data set. But we have to be very careful for this one. So if we have problem with all these things, like in the data and all, we can do the always the data augmentation. So to overcome the small diversity of the label data set, data augmentation, as I said, is a technique that is used to increase the number of imaging without adding a new image, flipping, padding, rotation. And we can also do the oversampling or undersampling to increase or decrease the count of the data set, right? And then data imbalance is one of the problem, right, that faces researchers when they solve the problem by using DL, right? In the data set, number of images that have disease is larger than the yeah, this is the common problem which I was discussing. So number of images that have the disease is larger than images with no disease, in which all the cause and implements the data set. So this we have to see, and this is very unfortunate problem. So we have to be very careful. For example, if you train and test wrong data set, if you train with the wrong data set, your whole prediction, your whole accuracy goes for toss. You will have totally different thing, because the input you are giving wrong. How you can expect output to be the perfect? So we have to be very careful. Then undersampling and oversampling are two common technique, as I said, to enhance the data imbalance problem, right? Undersampling is done, it is the process by deleting randomly the data. Oversampling is another method by which you can increase the amount of data, right, to if there is a data imbalance problem. And padding is another way. So there are different ways. If you search on internet, what are the ways to handle the data imbalance, you will find a number of ways, and you can do it anyway. So these are the things, these are the literatures. So the different method to balance the different classes. So you can, so this is the kind of literature survey. So they have used MRI modality, and then their data sets, that OSIS they have, somebody has used OSIS, somebody has used ADNI, right? So, and these are the contributions, advantages and disadvantages. So in the references I have given, all the references I have given. So if anybody is interested, they can go to the reference. Next one is the multimodality images in the classification. So there is a different scan type of the neuroimaging, such as the magnetic, MRI. So as I said, these are the different techniques by which we can take the image. So to solve this problem, multimodal image is classification. What we can do is, to solve this problem, every single modality is learning separately by multi hidden layer to extract features, right? And a combination of the features from the different modality has the high performance than the training. And then the collecting the necessary information. So it is also required to collect the necessary information from the images which we get either from the MRI, CT scan, or other things. So there are the in the table presented here, we compare different studies on how they collecting important information in image, and how the other things are done, other disadvantages, right? So these are the studies which were done, and these are the modalities like MRI were mainly used, and data set which we discussed, either ADNI or the OSIS. And these are the contributions and the advantages of that one, and these are the disadvantages of that method. Then next one is a neuroimage noise manipulation. So adversarial noise may be found in the neuroimages, and it can reduce the performance of a classification process. So this is another problem. So we have to to minimize the noise. We can see that the number of study which have been done. So uh, classifier they have used is CNN also. And if you see, there is ANN, artificial neural network, but in the three studies here they have used a CNN. So CNN is most popular, and then data set they have used, if you see the most of them, the data set they have used is ADNI, right? And then the contribution, advantages and the disadvantages of each neuroimages noise manipulation technique. Then in the overfitting problem is another challenge which we have to tackle, and it is a very common problem. So overfitting happens when the model is trained on data that have noise and more unuseful details. So if you train the data without having the denoising technique or pre-processing technique, which I have discussed in previous slides for the pre-processing of data, then overfitting will be the another problem which you might face in a subsequent classification. The size of data used for the training may not be enough is also one of the reason that cause of overfitting in this case. To solve the problem, we need to increase the amount of data. How do we increase the amount of data? By oversampling. If it is more and we want less, we have to downsample it. So these are the techniques which we can use to avoid the overfitting problems and then challenges. So these are the references you can see. So CNN is used, CNN is used, VGG, they have used classifier deep learning models, and these are the contribution advantages and then the accuracy. You see that some of them have reported 99. I don't know how authentic it is. I have not yet tested, but 95%, 86% looks good. 92% also looks good. 85, 80%, but 99% it is too good to believe. But if they have reported, I can't comment unless we replicate this study. And then we have the hybrid approach, where we have a combination of many approaches to take the challenges, to handle these challenges. There can be a number of ways. Okay, so what can be done? What are the future directions? So these are the points which we can take into the account. So one of the challenges is collecting brain balanced and sufficient data related to the Alzheimer disease. Deep learning segmentation can be injected in the process to specify only the region of the interest. Combining two various conceptual methods of the sparse regression DL to diagnose AD can be effective. So there is no any golden rule. There is no any ready-made rule for tackling any problem. It is it is it is it all depends on your design of experiment. It all depends on what you intend to do. It all depends what data set you take. So we have to be careful at every steps we take in the study you perform, and challenges are going to come in every phase of the study. So, and there is no any written rule to tackle the challenges for the specific task. It is like based on the knowledge, based on the literature, and based on the trials, you can opt the strategies to avoid the challenge. Okay, so the scope of presentation was done until this one. So whatever we have seen so far is how to predict the Alzheimer disease based on deep learning methodology. This was to estimate, but if time permits and if I am allowed, then I have few slides for Alzheimer disease reversal technique, which is a very hot topic nowadays in the field of the research. Researchers are doing a lot of effort to reverse the process of Alzheimer, and it is animal trials has been done, and now a lot of trial is going on the human as well. And we in a QNeuro are also working in a part of it, which is called as a brain stimulation. So if I am permitted and if time permits,
Yes, sir.
then
Please, sir. Please.
okay, thank you. So I would like to come to the new fresh topic, which is called as a brain stimulation, which we are currently doing in our office also, company also. So in brain stimulation, as name says, we stimulate the brain. And how do we do? There are different ways to stimulate the brain. So there are two ways mainly. One is we inject the current to the brain, which is called as transcranial electrical stimulation, and we inject the magnetic field to the scalp. Here you can see here, this is the electrical stimulation and this is the magnetic stimulation. So there are two ways by which we can stimulate the brain. There are many research which there are many there are many fields and researchers have established that if we give the electrical stimulation, especially the TACS, which I'll discuss in a subsequent slide, then the Alzheimer can be reversed. So this is the very big claim in today's research community, but it is there. So now let's talk about the electrical stimulation. So there are two, as we all know, it is very basic science. There are two types of current, AC and DC. So when we inject the direct current, it is called as a TDCS, transcranial direct current stimulation. If it is TACS, it is called as a transcranial alternating current stimulation, right? So this is TDCS, this is the TACS. You can see here the current is given, it is a direct current, it is flat line. Here we can see it is alternating current, right? So the sorry, two types of current is given to the different parts of the head. So I have not included the detail of it, but to not scare you, I must tell you that the current intensity sorry, which we give is of very less intensity. It is somewhere around -4 milliamp to +4 milliamp. So it is very less. Meaning, when we tested on ourselves, we felt that it was just we just got a tingling sensation, or when we put it on the frontal head, we got phosphene effect, meaning something was shining, or it is like how like lightning is happening during that rainy days, right? So that lightning kind of thing you can sense when you put this stimulator and the electrode in front and give the milliamp range of current. So application of TDCS, it has a huge application. So as I said, it has a application in stroke recovery, Parkinson disease, depression, anxiety, PTSD, schizophrenia, memory and learning, attention, problem solving, chronic pain, a lot of acquisition, rehabilitation, substance use disorder, and insomnia. So based on this one, there are few products which have come in a market based on the TDCS, and a lot of physicians and the physicians actually use this TDCS to treat the patient, and it is again it is there is a huge scope of research in this field on a different diseases. I think NIMHANS, there are a lot of research is going on in the NIMHANS also on the brain stimulation and the neuromodulation. So that was the application of the TDCS. Now I'll discuss about the TACS. In the TDCS, we used to give the direct current. In the TACS, we used to give the alternating current. So in the alternating current, again, the magnitude which we give is -2 amp to plus -2 milliampere to +2 milliampere peak to peak. It is not the RMS one. So that is the strength of the current we give, and we can see a lot of actually applications are there, like cognitive enhancement. People actually researchers actually claim this also, that it can also used for the cognitive enhancement, treatment of the neurological disorder like Parkinson, Alzheimer, dementia, epilepsy. A lot of things can be done. So since it was not the scope of the today's presentation, I have given the glimpse and glance of this one. and then depression, anxiety, PTSD, insomnia, sleep disorder, chronic pain, motor recovery, neuroplasticity, substance use disorder, synchronization of beta, alpha, theta, and delta wave. So this is very important thing. For example, there is one product also in the market by the company called Elimind. So they have come with a one very nice product. I don't know if they are doing this thing in their product. So what happen is, for example, if we have in the calm stage, in EEG, your alpha will be like something like this one, right? And it will be somewhere around 8 to 12 hertz, right? Some people say it is 7 to 11 or all those things, but I'll just take 8 to 12 hertz is alpha, right? In some person, when they relax, this is not dominant. The alpha is not dominant because of some neurological disorder, or if they are not keeping calm and all those things. But if it is between 8 to 12, your alpha is good, you are in calm stage. So in this kind of people, what we do is we give TACS, transcranial current, which has frequency of 8 hertz or 10 hertz. So when we give this treatment, this TSS to the human head, what happens? The neuromodulation or the neurons will try to entrain and try to align with this wave. So if we train and give the proper training, their neurons also start firing in same fashion. So by that way we train it well. So this is the kind of things which a lot of research. I just give you the food for thought in this manner. So a lot of scopes are there in that field. So this is our product actually. This is for the TDCS. In the TDCS, we have the little bigger electrode. So this is the foam, sponge, metallic casing, and this is the plastic casing, and here is a hole for putting the saline water, and we put it on the scalp like how it is shown here, like here, over here, and over here. So in the TDCS, one is cathode, other is anode. So current flows through the anode to cathode, and by that way, so when current flows from here to here, what happens? The thing is, your neuron firing will happen with the consistent rate. Your neurons will start firing accordingly. So by that way, this is the hypothesis of the many researchers, though, but it has been proven in the animal a lot. It has been proven in the mice especially, and on the human subject also it is underway. So this is our product which we have made. So what we have done is this is our EEG device, EEG strap. One of the form factor of the EEG device is EEG strap. Our flagship product is EEG hat. You can go through the qneuro.com and see the picture of the product. Uh, so this is another product which we have, which is strap. What we have done in this one is this already has the EEG hybrid EEG electrodes, and in addition to this, what we have given is we have treated this subject as a TSCS electrode as well, or the TDCS. So what we do is we inject the current through this all the electrodes, okay, for maybe around 15 to 20 minutes, okay, and then we record the EEG, okay, and we switch off the TSCS when we record the EEG, and then again we give the injection. So the bottom line of this story is we first inject the current, record the EEG, inject the current, and we see if there is an improvement in the subject. And this is not one day practice. This has to go for many days to see what is the trend in the EEG which is reflecting, right? So these are the electrodes, and this is the electrode processing. This is the motherboard for all this. So it can be fixed at the back, and switch for the EEG streaming and TDCS or the TSCS. Okay, so there are the switch. So if we push or pull, whatever it is, your EEG is on. When you pull back, your TSCS or TDCS is on. So it is all software operated as well, and you can have, and this is connected. This device is connected through the this either phone or desktop or any host device through this Bluetooth module. So that is how we are doing. So these are the references I have given where I have cited in my presentation in the earlier slides. Thank you so much. So this was from my side. Should you have any question, I would be very answer to. I will be very happy to answer.
Yes, sir.
Thank you, sir, for your nice session.
Hello.
Thank you.
If anybody is having any specific questions, either you can unmute and ask, or you can type in the chat window, please.
Sir, sir, we are using the electrical stimulation, sir, for reverse
Okay.
Alzheimer's disease. For using that AC voltage, for around you told that from minus to plus 2 milliamps amount of voltage you are giving.
Yes.
For how much time you have to give for that one, sir?
So again, it varies. So you have to give for 10 to 20 minutes.
Okay, sir. So can
Yeah.
it in magnetic simulation your company is doing or not, sir? For magnetic.
Yes. We do have. Yes. Yes.
Okay. Nice presentation, sir. Thank you very much.
Thank you so much.
Sir, actually, during the collections, what type of data it will be comes through the phone or laptop? Whether it is an
It is compatible with
raw
both.
data?
In which you are saying which data?
Actually, from the device, what type of data it will be? I think it will be available in terms of Excel sheet or it may be
Excel. Yes.
Bluetooth through which, yeah, Excel in terms of microvolts, in terms of what are the
EEG
electrodes
data you are
located.
talking about? EEG data?
Yeah.
Of course. Yeah. Microvolt. Yeah. Yes, so you will get both. So the raw data as well as the filter data. So it's up to you what you want to choose. For example, if you want to just use the data for your application, you can use the filter data. Or if you want to do the analysis yourself, right? Then in that case, you can just choose the raw data and do your own processing.
Okay, sir. Okay, sir, one more question. As you
Yeah.
told that hybrid techniques,
Mm-hmm.
hybrid techniques in the sense I need to combine two or more models such that in order to improve the performance metrics of deep learning techniques or something
Exactly.
else.
Yes. Yes. So as I said, there is no any hard and fast rule that this is the this specific models will give you the good accuracy, but you can go for the hybrid model also at the specific point of consideration. Where you can see the as I show you that I shown you that somebody is getting 99% accuracy also. I don't know
Yeah, yeah,
until
yeah,
what level they were correct, but we have
yeah,
to because we have also experience because when we do the because in our company also first we do the research and then we implement, right?
yeah.
So most of the time what we have also seen is while doing the literature survey we come up with some kind of claim by some researchers, and when we replicate exactly the story is different, right? So
Oh,
don't blindly trust on any literature. So there your wisdom also comes in a picture, right? Saying by that way I'm saying is don't blindly trust any data set or any result. uh, Take the essence of that study, implement it yourself, and then check and test.
okay, sir. Okay, sir. Sir, what about the cost of the device, sir? What you told you got already filed a patent for this product. What about the cost of the device, sir? Roughly around.
For the TSCS and TDCS, we have not yet done the product costing because we have not yet released. But EEG device we have released in USA and Canada, which is already we are selling that one. The hat, I'll show you. Uh, is my screen visible?
Yeah, sir.
Okay, so these are the hat. This is the hat. we sell. If you see here is a all motherboard, power button. At this side is a battery. It's gives a best look. So it is inside of the hat.
Oh,
All the
yeah.
electrodes are there, right? And then
Okay.
you get the data in your host device. Host device can be your tab, phone, even your laptop also, right?
So
So
how many
this
number
we are
of
selling.
channels, sir?
Sorry,
How many numbers of channels supported?
it is a 8 channel.
Oh,
Yeah. So it's a okay. I don't know if you can stream. So yeah. So what I'm saying
yeah.
is this we are selling in the USA and Canada, and we are selling for the right now $799, $799.
Oh,
Yeah.
okay, sir. Okay.
Sir, what communication device it is used for this one, sir? Communication technology between
It's a Bluetooth.
It's Bluetooth technology.
Bluetooth means the range only the 10 meters. Is it okay for that, sir?
Yeah, its range is only 10 minutes. So when you have your phone, definitely if you are using outdoors, you will have phone in your pocket, right?
Yes, sir.
So your pocket to this cap, it will be hardly 1 or 2 meters, but our range is 10 meters.
Yes, sir. But suppose the radiation generated by Bluetooth it is affected by brain. Is it possible, sir?
No, it doesn't radiate. So it has a certain. It operates in a certain frequency. It operates on a 2.4 gigahertz to 2.48 gigahertz. That is a dedicated frequency for Bluetooth. It doesn't affect it is purely safe and it is FCC approved. It is like CE.
Oh,
You'd have heard of CE, right?
yes.
So C certification is required to sell the product in European Union, whereas FCC certification is required to sell the device in US and Canada. So our device is FCC approved, meaning it is safe to wear it. It comes under wearable device.
Thank you, sir. Thank you.
Yeah.
Sir, whether that AC or DC current that we are applying for this applications, whether it is bearable to the human,
You are talking about the brain stimulation.
yeah,
So of course.
for acquiring those type of signals, whether we need to have any protocols or otherwise we need to get permissions from the any other protocol methods will be there
Yeah,
for
of course,
this.
ethical committee is required. If you are doing the test on the general public, you have to definitely take the ethical clearance. But from safety point of view, yeah, it is purely safe. The magnitude of the current we inject is very minimal. It is
Oh,
-2 milliamp to +2 milliamp, peak to peak, right?
yeah.
So with that minimal current, I have tested personally. So
Oh,
it will be like tingling. In the beginning, you will find tingling sensation.
oh, okay,
Okay,
okay.
and little bit if you are putting the electrode on your forehead, right? You
Oh,
will have the phosphine effect, meaning you will feel that somebody is flashing light
okay,
when you
okay.
close your eyes and somebody is flashing light on your in front of you. How it feels? It
Yeah,
will
yeah,
feel
sir.
like that in the beginning.
Yes, sir. Yes. Thank you, sir.
Sir, there are a few questions in the chat window. Can you suggest any biomarker which will help in early diagnosis of Alzheimer?
I just let me just open. There are many biomarkers available on internet. There are not one biomarker which I can name one. So uh,
Beta amyloid, as you said.
that's a beta amyloid is, yeah, that is one, but you can't trace that one. Or the tau protein, right? So that is that fragment. One is inside the cell, one is outside the cell, and it degenerates, and because of that, your neuron degenerates and your brain shrinks. So yeah, that it can be taken. Then thank for the electrical stimulation. The same EEG electrode, okay, can be used. Yeah, so replying to Rohit Gupta, so yeah, we can, that is what we are doing right now currently. Right now, what we have is a separate system. EEG is separate, and then TSES and then the electrical stimulation is separate. But one of the patent we have filed is to combine both, which I shown in the last slide. Yeah, it can be done. But these two, EEG and TSES, cannot be used simultaneously. Otherwise, EEG recording will go for toss. You can't record this thing, EEG signal from your scalp while injecting the current in your scalp. Speech modification, gait modification happens to other disease as well. How do you ensure specificity? Yeah, this is another challenge. Yeah, this nice question, Sajita Nair. Yeah, so for that, multimodal other symptoms has to be also watched along with the speech and then the gait. Of course, there can be other root cause for this deterioration as well. So can you neurofeedback training be done with the device? Of course, it can be done. Yes, Lisa Daniel. Yeah, of course, it can be done, and we are doing a lot of work on the neurofeedback. So soon we are going to also release the cap which I shown you in India, where we will be introducing this as well for the researchers also. So we are releasing for both the communities. One is for the general consumer, and as other is for the research community. So yeah. Hey Malata Ohal, how about using EEG instead of image for the AD detection, and if flags in and which? Yeah, it can. Yeah, as I said, you can take the EEG. Since I didn't have liberty to, cover all the topics, because if I cover everything, then it will be very big presentation, and in a limited time, I could do only with the imaging. So of course, you can do. Can we monitor AD progression by some way? Progression by some way, I'm not sure AD progression if we can do, but I think but again, same way, if we can use the ALNDL, because I have not personally worked on it, predicting of it, but I think it can be, but I'm not sure if it can be. How will you differentiate? There should be some features for example, for mild, for beginning, for mild, and for severe case. There should be some features which you can extract from the uh, CNN. For example, if you take the CNN, from the feature of the CNN, you can extract, and then you can classify that if it is mild, moderate, or severe. Okay, so yeah, I think that's the questions I have right now.
Yes, sir. Yes, sir. Sir, what kind of significant improvement we can expect after doing transcranial current stimulation or magnetic stimulation? And what is when do you prefer current stimulation? When prefer magnetic stimulation? Is there any?
So your first question was how effective it is, right?
Yes, sir. Yes, sir.
Well, again, it is there is no any commercial device which has come in a market, including ourselves also. We are still testing how effective it is going to be, because TSES and TDCS has a lot of application, but what we are taking is Alzheimer, right? So I'll talk on the Alzheimer perspective. So we are still doing the testing, and we have not come to the conclusion that how much effective it it can be. It is still in a testing and validation phase.
Excuse
And
me.
yes,
Excuse me, sir. Can I ask a question?
yes, please.
Sir, how do you think this transcranial stimulation can modify or enhance healing for Alzheimer's? So, what is the idea? Like, are you stimulating any particular region of the brain, or you're applying it all over the brain? I mean, your
Yeah.
cap electrodes are all over the skull. It's seen like that. So, what is the idea? What is the principle you are using?
Okay. So for that one, definitely you go for first MRI scan or kind of scan, and we
Yes.
see that what area of your brain is affected, right?
Yes.
And based on that one, we give the treatment. For example, if it is an temporal lobe or occipital or parietal, I don't know. So based on that one, we stimulate the transcranial brain stimulation, and
Okay.
yeah, and there are nowadays so high density transcranial current stimulation has also come, where we can go a little more deeper on a brain cortex. So a lot of research going on in that direction, and few researchers have claimed that they could see the improvement in the Alzheimer patients. But again, I would say unless we do it ourselves, unless we replicate ourselves, let's not blindly believe anybody claiming based on the research paper, right? But there are
Can,
few things. Yeah.
can it improve the secretion of acetylcholine, or can it enhance the quantity of acetylcholine? Because acetylcholine depletion is always observed in Alzheimer's.
Yes.
So, can this kind of stimulation modify the amount of neurotransmitter?
At the biological level, it is still unknown.
Yes.
People are still researching that can that be stopped, or it can enhance. It enhance enhance the or decrease the impairment of the neurons, or degradation of neurons. So scientists still trying to understand that part. But at the physiological level, people have seen the improvement in the patient after giving at a certain episodes of the transcript. For example, for episode of 20 days with the duration of 20 minutes. With that episodic treatment, they could see the improvement in the patient. So based on that, they are saying, but at the biological level, they are still trying to understand.
Sir, will it cause any harmful effects? Like, can it elicit some kind of epileptic seizures or something if we stimulate like this?
Short term effect or harm is not there, but long term harm is still unknown, because this has come very recently. I think it is just 3, 4, 5 years old. It has come when people start using this TACS for exploring different applications. So long term effect is still unknown, but short term effect is not there except this tingling.
Okay.
Somebody has reported localized skin redness, very mild skin burn, not burn. In fact, there was the redness, skin redness, itching, all sort of minor things. But yeah, severe consequences has still been not reported.
Okay, okay. This is a very interesting presentation, sir, because Alzheimer's is, or all kinds of dementias are very difficult to.
Yes, yes.
So this is really interesting.
Thank you.
Thank you for the presentation.
Thank you.
Sir, actually, for Parkinson disease, we used to take some subcortical regions from the brain. Normally, left caudate, right caudate, putamen, something like that. From there, we used to take radiological features like but in the case of Alzheimer's, could you please any particular subcortical regions which may be focused on? Could you suggest any subcortical region?
For Alzheimer's, it's not in my knowledge though at this point of time, because yeah.
But as you said, one of my research scholar also is working in this particular area. Especially as you said, one of the benchmarks data set ADNI, there we'll be seeing the 5 different classes.
Okay.
Normal, mild cognitive impairment, early, late cognitive impairment, and Alzheimer's disease. And this file format is nifty, neuroinformatic transaction initiative. In real time also in industry, does it comes in nifty format only?
I think so.
Okay.
I need to ask. You can actually email that to me. I'll check with my team.
Okay.
Yeah.
So we are getting even now with recent models and all, 5 class classification is very tricky and very not a very good results we are getting for 5 classes. I mean to say normal, mild, late,
Yeah.
and then AD. Yes, sir.
Okay. What techniques you are using?
So by in literature there are by mingling even multiple networks, focusing on global features, local features.
Okay.
Simple convolution neural network or any simple architecture is not working. Definitely very poor results we are getting. By in literature we are observing that recently integrating different types of architectures, future fusion in literature it is available.
Yeah.
But till now, fortunately or unfortunately, we are not able to replicate the same results using the same architecture. We are getting poor results only with respect to 5 class. I mean to say, for 2 classes is okay. If you take only normal and AD, we can succeed. We have succeeded.
Yeah. You can probably include more optimized hybrid approach.
Yes, sir. We have to work on it.
Yeah.
Till now, it is not very good results we have obtained with respect to 5 class classification.
Yeah, but on contrary, if you see on a literature, they claim like 95, 99 and all that.
Okay. Okay. Thank you. I think there are no more questions from the participants. Thank you very much for your very nice presentation, and we have got the very recent technological input from your side.
Thank you so much, sir.
Thank you, sir. Thanks a lot.
Thank you,
Rahul, for my side also. Personally, thanks.
Thank you, sir. Thank you. Thanks, everyone.
Thank you, sir.